Be looking at specifically the eyeball and eyelid in the anatomy of the sclera. So eyeball, you're going to be looking for size. Are they symmetrical? Setting in orbit. So as you guys know, exophthalmos can be indicative of Graves. That's like that bulging eyeball effect. And then inophthalmos, which is the retraction of the eyeball, and that can be indicative of just muscle weakness. And then eyelid, you want to look and make sure there's no lesions, swelling, scars. You can also look at the lacrimal gland on the lateral aspect, kind of the eyebrow there, and you can actually have them hold that, or you can hold it and have the patient look medially. And that can be indicative of sarcoidosis if that's hard for the patient to look medially, but that's kind of a minute detail, I think. And then the anatomy of this sclera, of course, we all know if that's yellow, it's jaundice. White should be, or is normal. And then for the fundoscopic exam, okay, so I haven't done this since Tri-4. I did it today, like twice, so show me some grace here. But as you guys probably remember, Dr. Hall did a good job of nailing it into our heads. You're looking for three things, and that's the red reflex. If that's absence, it's, what is it? Do you guys know? Cataracts. What's up? Cataracts. And then you're also looking for the disc. So the disc is, if you guys remember, and I'll do it in a second, try to do it. What is this? I don't know. So you start at lateral aspect, and that's where you're looking for that red light reflex. And then as you go more medially towards the patient, that's when you're looking for that translucent disc. Do you guys remember that? And you're looking for what? Cup to disc ratio. That's next, Baylor. Cup to disc ratio. So I had to look that up because honestly, I just memorized the script for Tri-4. But what that is, it's a 1-to-2 ratio. So the disc should be 2, the cup is 1. So that means that the disc is bigger. It's really hard to see on an actual exam, but we Googled it, and what it is the disc is translucent, and then that cup is even more translucent. So it just really looks like a white area, but if it's bigger, then that's an abnormal finding. And then the last thing, Baylor, is what? Yes, AV nicking. And what that is really showing us, we want the AV nicking. Well, also you can look for the AV ratio, and that should be 2 to 3. And what that means is that the arteries should be lesser in diameter than the veins. But that AV nicking, if that is apparent, that means that an artery and a vein are crossing, and the arteries are darker in color than veins. Veins should be more white. And if those are crossing kind of near that cup to disc ratio, or cup to disc, excuse me, cup and disc, but that can be indicative of hypertension. So just know that. So the three main things to review: red reflex, absent, cataracts. Disc to cup ratio, you want it 1 to 2, but it's just that translucent light. And then AV nicking is hypertension. Now we can go into the exam. I'm going to do it unilaterally, but of course you would do it bilaterally in an actual scenario. So the main thing to remember is I'm going to assess Andrew's right eye, so you want to use your right hand. And then I can't remember. Does anyone remember what Dr. Hall had us start off on?
Hey, do that side so I can video it.
Oh, that's my worst side, but left. Okay, that's practice too. But does anyone remember it?
Is it 0?
Okay. Is it 0 and then you go to red, or you go to green?
You start blurry and then like you move it on your own and try to follow, and it starts to get clear. And that's when you start making decisions.
You start at green 6.
I used a Panoptic.
Fancy.
So I actually never used one of these.
Okay, so I think the main thing is see where you can
So
see
mine,
it.
you came in from the side, then you rolled up. Once you saw the red reflex, you brought it up, and then you came in.
Yeah. But you go
Find a, so look at the wall and find a point and focus it.
Yeah.
So look at a distance, find a point, focus it,
Okay.
and then look at him.
Okay.
So look at his eye. And if you need to further focus it, if you can't see anything, you can continue to focus.
Okay. Kate, thank you.
I can't actually see anything through that, no matter how much I focus it, but I remember what he did.
Okay.
Wider, Andrew.
So I'm starting. And you can hold the patient's head too. And you're supposed to have your pinky out, and that should be the length of, or the amount of closeness. You remember, you guys, we get pretty close. So yeah. Okay, so I'm not going to talk. I'm just going to kind of do it, or try to. Let's see. So I see that red light reflex going across. Okay, and I saw the cup. Do you guys remember how you have to go kind of a little bit inferior to look up to see that cup and disc? But I didn't see any AV necking, so awesome. And you have a red light reflex, so you don't have cataracts.
Going over the lymph nodes, because just watched a video on it, so pretty cool. So bad news is if they're hard and they don't move and they're large, that's bad. So you want to get that checked out. It's very true. We went over it. They should be soft and slightly tender, correct, and movable.
Well, they don't have to be tender. Tender would be like a viral infection.
But that viral infection. So
Hard is also indicative of mono,
yeah.
especially if they're under submental.
Okay, so first you could do periauricular and post here, and then you get down to submandibular, and then further down submental, and then you could do the cervical lymph nodes, so if on SEM, do the anterior portion, and then you can do the posterior cervical lymph nodes, and then you get further down.
Supraclavicular.
And supraclavicular, you have to like go to the clavicle, and you want to have them bear down, or you can cough. Or you can cough, so you have to cough. Sometimes you can feel a lymph node or a hard node. So there's the lymph nodes. Next, we can go into the ear. So the ear is fun. So for the ear, there's two portions, just kind of like the eye. So you have external and the internal portion. So for the external portion, you're basically just looking at the outer ear itself, noting for any redness, any enlargement. You can get like, you can see like sometimes the parotid gland will be increased in size too, so you can see that right underneath the ear. So here you're looking for any like redness, which would be polychondritis, or bluish, which is the ochronosis. And then pain on movement, swing around so she can get on the video. Pain on movement could be external, otitis externa, basically. So, and then when you do the exam looking inside in the ear canal, if it's red or swollen, that's otitis externa as well. So that's pretty much the outer ear portion. Going into
What's most, when it's an outer ear infection, what's most commonly the cause of that? Swimmer's ear. You don't have to be swimming to get it.
okay, so
Water will drain from the ear too. A lot of times they'll feel like it'll feel muffled or like cottony. Everything will be muffled to that person, and they'll feel like their ear is draining the water.
moving into the internal ear, make sure you pull posterior and superior in adults, and then posterior and inferior on children, because it lines up the membrane with the canal so you can see it properly. You're going to look for, basically looking at the tympanic membrane, should be pearly gray, should be translucent in a neutral position, should have a normal light reflex, so the cone of light should be on the anterior inferior portion of the tympanic membrane. So issues you can get here, you can get red and loss of landmarks, that's otitis media. If it's amber or like some sort of effusion, right? Like contracted more so. It's like it's like a pressure issue more so. What's it called? Barotrauma is when it's like retracted inward. You can have bulging, which is also otitis media, and then it can be air fluid filled, translucent, which is otitis media as well. You can have hemorrhaging of the vesicles, which is the bullous meningitis. It's like literally vesicle just bulged out. It's pretty obvious to see. And then obviously you can have perforation or holes below your eardrum.
And then a bulging membrane is typically due to pus. It's typically bacterial. If it's retracted, it's typically a viral. So it's good to know if someone wanted an antibiotic or not.
So hold it like a pencil. You can use your pinky to kind of use as a fulcrum. So we come in. Let's do superior. Right here. And Brian's very hairy. And you need to clean your ears off. You want earwax.
I literally do it every other day.
You know,
not
it
even
just
kidding.
pushes in, right?
Yeah, you
The
need to use like
Q-tip
soap
makes
and
it
water.
worse.
I mean, what do you want me to do?
Soap and water.
So rude to your
Every-
patient, Andrew.
Very cleanly. My
Now,
hygiene
if you're
is
in a state and you're going to be
Yeah.
doing like ear exams, like you better be prepared to be able to pull out the wax to then be able to get in there.
Oh,
'Cause
yeah.
A lot of people have wax buildup, so they have the little scoops when you actually get the wax out to then be able to look in the ear and see the tympanic membrane.
So next for the nose. So find these notes.
a lot of room to work with.
I know. So for the nose, you just want to look right away for any kind of deviation or anything obvious, like
I was born this way.
potential fractures.
Again.
So anything abnormal could be septum deviation, perforation, could be abusing cocaine. So you want to look for that. Edema, acute rhinitis, swollen, pale or boggy, and gray could be allergic rhinitis, and pustules could be furuncles. Nasal passages, if there's any pus, then it's probably sinusitis. So for that, you would literally just
Tell me words.
like this way, and then you go in the side look up, and then you can come in, basically just a little bit here, and a little bit here, and that's nice. So that's pretty much how you would do it.
And then the sinus infection.
Yeah, you can tap. We didn't have that on the notes, but yeah, you can just tap for the sinus infection. So it would be here, percussion.
Are you checking for tenderness, or are you feeling for like
Tenderness.
Tenderness, yeah.
If someone has a sinus infection, that whole this
Isn't
is going to be
it-
enough to hurt.
Can't you put the light up too?
You can. You just
Yeah.
stick it underneath, and then you can look for the shadow. If the light doesn't go through,
Yeah.
then it's full.
I can do that, but I couldn't be here. Okay, so next for the mouth. So for this one, externally, you would kind of want to just look and make sure that there's no cyanosis or pallor or anemia, kind of pale-looking lips. Brian, you look pretty good. So basically, you get your tongue depressor, which Song gave me. Thank you, Song. You want to do this? Okay. So for here, you want to look for any redness in the pharynx or any enlarged tonsils. Could be tonsillitis or lymphoma. Could be pharyngitis, viral or mono or strep if there's redness in the pharynx. Also, cranial nerve stuff, failure of the soft palate to arise when they say ah, deviation to the opposite side could be paralysis of the vagus nerve. There's a whole bunch of stuff. I mean, defects could be cleft lip. That's pretty obvious externally. There could be ulcers inside or blisters. Blisters could be herpes simplex on the outer rim too. Okay, so go ahead and you come in basically use the pin light, have the patient open up and say ah, and then if you need the tongue, can you open up and say ah?
You just.
Ryan looks great. I didn't put it in his mouth.
Okay.
Yeah. So there's my exam, and I will review everything I just did on your own time.
Because that can irritate patients. So you should use like coffee, I think is like the best one to use. I don't have coffee with me, but I would have the patient close her eyes and cover one of her nostrils, and I have it in my hand. I would take a deep breath in. Can she identify the smell? And then I have her do the other side. Can she identify the smell? Is the intensity the same side to side? And that's all there is for cranial nerve 1. And then cranial nerve 2 is optic. So you would do a fundoscopic exam, just the same thing, looking for red light reflex, AV nicking, papilledema, all that. And then you would do pie in the sky, which face me. I'm going to scoot your back just a little bit. So you're going to have the patient cover one of their eyes and have them look at like a neutral spot, so maybe like the top of my shirt right here. And I'm gonna tell her that I'm gonna put up a 1, 2, or 5 on like both my hands in 3 spots, and she has to identify it, keeping her eyes here. So. 1, 1, 5. And so you never choose 2. That's just like a distractor to confuse the patient, because if they see 2, that's something's obviously wrong. And then, do we need to do visual acuity? Like Snellen chart? Okay, so that's on there, but they don't need to do it. All right, and then
Should
for
know how far away.
yeah, okay, so for the Snellen chart, it will be 20 feet away, and then for the near, like pocket chart, it's 14 inches. I think so.
I care more about the bigger one.
Yeah, okay, 20 feet away for Snellen chart. And then for cranial nerves 2 and 3, we have direct and consensual light. I've heard some sources say to not use a pen light, to use an ophthalmoscope. I don't know if it makes a difference.
I always use a pen light, but
Okay.
you can't use an ophthalmoscope.
I got both, but it's okay. So for this one, you're going to stand to the stand to the side of the patient, and you're going to put the light into one eye, and both eyes should constrict. So you'll do it twice. One, look in the eye that you're shining in, and then look in the other one for the opposite. So both of them constrict. If I shine the light in one eye and both eyes don't constrict, that would be a sensory or cranial nerve 2 lesion on the side that I shine the light in. And then if I shine the light and only one eye doesn't constrict, the eye that doesn't constrict, cranial nerve 3 is lesion. So if I shine it in her right eye and her left eye doesn't constrict, it's cranial nerve 3 on the left. Okay, and then swinging light is just same thing. And then you're gonna hold the light for like 1 to 2 seconds on each people. And you're watching for pupillary fatigue and making sure that the pupil constricts and holds for like 1 to 2 seconds, and then goes back out. Okay, and then just for cranial nerve 3, basically this one, you're just gonna observe with the eyes open for ptosis, shining of the eyelids, or anisocoria, different side pupils, and then with their eyes closed, you're observing for microspasms of the eyelids. And then accommodation. Look at the toxic sign, and you're gonna have a spot that's about like here in front of her nose, and you're gonna have them go from here to far. Far. And as she comes near, she should, her pupil should constrict, and there should be a thickening of the lens. And then there's convergence, which will stand in front of the patient, anything like about here for the patient, and then you're gonna draw the fingernail to the nose and then out. So she constricts as she converges again. And she should be able to smoothly track that. Okay, and then for cranial nerves 3, 4, and 6, we have H and X in space. So she's going to follow my finger as I do an H and an X in space. I should hold it, it'll take a while, but we should go at least like 3 to 4 times, and then you stop at the end point, and then you go to the other end point. So I'm going to go stop there. And the point of the stop is to look for an end stage nystagmus, and as you're doing the pursuit, you should be seeing if you can follow it or if it's not smooth. Yes, okay. And cranial nerve 5, sensory. The 3 branches, B1, B2, B3. So eyes closed. Yes, always. So I have her eyes closed. Your B1 would be up here. Feel that all the way through. Show that all the way through. See the same side to side. And then you do B2, B3. Alright, and then for motor of 5, for the masseter and temporalis, she's going to fight down. And I'm going to feel just the tone of the muscles here. And then opening against resistance for the cervix. close your eyes really tight. And then puff your cheeks out. And then smile. And then big smile. And then for cranial nerve 8, the hearing portion, so I'm gonna have her close her eyes. And I'm so you're gonna do like the finger rubbing next to their ear. Do this. And tell her to stop her. And then you do the other side there. And then for Weber and Renee, everyone's favorite, I'm gonna 120 or 512, 2 down to 5, or 120, whatever it is. And then ladder on one side. If it was, let's say if it was ladder on the right, I would put it on the right mastoid, and she would tell me when she can't hear it anymore, and then I would put it in front of her ear. If she can still hear it after I take it off the mastoid, that means it's a sensory neural loss on the contralateral side. So this side just can't hear, that's why I lateralized to this side. If it were the opposite, lateralized to the left, put on, or to the right, put on the right mastoid, took it off and she couldn't hear it, it would be inductive loss on the lateral side. And then for vestibular, there's a tandem gait. So I would have her walk heel to toe and make sure with your eyes open you're going to be staring in front of you, not looking at your feet. And make sure that they don't fall. But don't touch them. And good. And then have you come back and do it with your eyes closed. Same thing. Let them fall. Good. And then another test you can do for vestibular for cranial nerve 8 is Romberg. So just stand here with your feet together. Together. And then first she'll put her eyes open to get the bearings, and then close her eyes. And just think this way. And then resting nystagmus calls for vestibular consent. I would just have her like stare at my nose, and I'm gonna just look to see if there's a resting nystagmus. And it's good when you're trying to observe both the eyes to look at the top of the bridge of the nose to see. And then cranial nerve 9 and 10, so we have palate elevation. So you use the light for this. So I'm going to have her say, ah, 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 like that. Yeah, so not like a ah, it's got to be like short ah, ah, so you're seeing if the palate elevates to the same, and if not, the uvula will deviate if there's a lesion, the opposite side of the lesion. And then gag reflex, which I won't do, but I will explain. You're going to have them open their mouth, and you're trying to poke kind of hard to the back of their throat to elicit the gag reflex, and you would do one on each side. Compare the responses.
Make sure if you're doing really actually focus.
Yeah,
Some people do it and you're like afraid. Like, you need to see if the person's gonna gag and it's gonna move.
Cranial nerve 11 tests the traps and SCM, so SCM basically. For traps, you're going to have them shrug their shoulders against resistance, and then SCM, you're going to have them rotate their head slightly and rotate my hand, so just head rotation into resistance. And then cranial nerve 12, first I'm just going to have her open her mouth, chunking your mouth, and I'm looking for a big one. Yeah, like that. I don't know. You're like putting it in the back of your mouth. So you're just looking for fasciculations, atrophy, yeah, just those two things. And then for tongue intrusion, I'm going to have her stick her tongue out and make sure it's midline, it's deviating to one side, it's the lesion on that side. And then tongue strength, with her mouth closed, she's going to put her tongue to one side. And I'm just going to do it again. And that's it.
Going down the arms or legs, you want to make sure you just fall over the neuro exam. So we'll do dermatomes first. So afterwards, put your patient into it down, make it easier to breathe this up. And then the most important thing with dermatomes, make sure the patient's eyes aren't closed throughout the exam. Okay, so I'll do C5 first. And then you just just want to make sure that the patient knows the pinwheel is not going to hurt. That's what it feels like. So you go down for C5, ask the intensity same all the way through, and then this one. And do it bilaterally. Intensity same all the way through, and then is it the same side to side? So that's C5. Come down to C6. Intensity all the way through. Do it side to side. Same side to side. And I'll just C7, bilaterally, side to side, C8, and then have the arms raised up, side to side, and then do T1 like this, side to side, bilateral.
Make sure when you're doing it on an exam, go all the way through the dermatome. Don't like cut it short and assume that the examiner's like, oh, they know where the rest of the dermatome is. Does that make sense?
Muscle strength, so you C5 first, and have the brace arms up. Push down, good. And then this, and then you want to come here and reinforce on the tricep. Good. Bilaterally. Here, push down, good. Do bilaterally. Escape. Finger flexors. Good. Side to side. And then we're going to do T1. Try to pull the fingers apart. Try to resist finger. Side to side, and then we'll do reflexes.
Do you do brachioradialis or is that not included?
Or
Smudge?
so for motor, you can. Some of them have more than one, as long as you know at least one. Each motor.
Okay, we'll just listen to that.
All right, so we'll do C5 first. Here. Okay, and then do it 2 times. And then we'll do C6 for the Dallas. Wacky wacky. Here.
That made me uncomfortable.
Triceps. Two times. And then
When you're doing reflexes, you should only use your thumb over the biceps reflex and the medial hamstring. If you have the triangular reflex hammer, the flat end should only be used on the Achilles. Just so you know. And then doing lower.
And then, so, yeah, so lower extremity.
What?
You have to see. Or
You want to?
Oh, you can do that one. I never made you do that.
Which one?
C8.
So yeah, you would use the back of it for that one too, for the C8. I didn't learn that
Just
one.
make it like say like you're going outside.
Yeah. I tend to forget that you learned it here.
So lower extremity, make sure the patient is in shorts, which I'm not. So do you want L1 and L2?
You guys all know where L1 and L2 is. You can be more comfortable in it.
We'll start with L4. So
I'd like to see
we'll do it later.
throughout the whole note.
All right, so pretend twins in shorts.
You're gonna have to take off your shoes anyways.
It sucks. So L4 you can come across top of the knee, medial leg into the medial foot. That's the same way through. Other side, side, here. And your eyes are closed throughout this exam. Do not look. And
You guys forget that all the time in IMA, so don't make fun.
L5 on the lateral side of the leg. And then, lateral side of the leg down to the second and third toe. As always, all through, side to side. And then S1 is on the lateral aspect of the foot. Do it bilaterally. Then you got reflexes. So we got 4, which is raise that chair.
And raise the chair up.
Yeah, raise the chair up. So you're not so much.
Other side.
You had it right the first time.
Okay, 2 plus, then do it bilaterally, and then do S Achilles here. 2 times, good. And then bilaterally, and then medial hamstring.
Like throwing on the table.
Come over here. So lay face up. Can I do it my way? When I do it?
No.
Gotta do it face down.
Yes.
Yes, up here. Okay, I felt it. That's they do that bilaterally, and then let's have you come back, sit down, chair.
There's only a small percentage of the population that they say that you will find that reflex.
I can actually feel it driving it. Push that back.
Push it back down.
All right, so have you come up, bring your leg up. Okay, and then do it bilaterally, and then we'll do push out or push down. Okay, and then push in. Good. Okay, and then put your push your foot up. Good, and down. Good, and then big toe, stand up. Good. Inversion, which is where you come in. What's this one? Good. Inversion. Good. Do that bilaterally. That was good. Muscle.
Upper motor neuron and cerebellum.
Okay, so for reflexes, you're gonna come lay down. Come lay down quick, face up. So for Babinski's, you'll have other reflex hammer. You'll have like a little pointing thing. You're seeing hold his down, his ankle down, and you're gonna come up in a C formation, real aggressive, and then you're just looking for the big toe to extend back and the other toes to kind of flare out with it. Normal would just be like a kicking motion, plantar flex. Sit back up. And then we'll do Hoffman's, which is the middle finger. You want to isolate the middle finger. And then you're just pushing down like that. And you're just looking for if thumb and index finger to approximate. That'd be a positive sign. Cerebellum.
Inverted supinator and clonus.
Oh, that's right. Okay, lay back down. So for clonus, you're just going to dorsiflex the foot aggressively. It's going to be this knee up a little flex, and then you're going to just aggressively push down, like push up like that. And then you're just looking for after you do that, the foot to kind of repetitively do that a couple times. And that would be a positive for clonus. Inverted supinator. Sit back up. I don't really remember the inverted supinator that well. I think it's
The radiostylide process. So you're just going to do this at the end of the brachioradialis. You're going to hit it, and then if the thumb and the first finger approximate, come together, that would be positive.
I don't know what you. I think that's yeah. So it's positive if they come together.
Yes.
Okay.
Now, you need to make sure that it's not the pressure of your hand that's forcing, you know what I'm saying?
Right.
Like just the power.
Yeah. Okay. So that's inverted supinator, which I didn't do very well. And then your cerebellum, so come over here, stand up. So you can do Romberg for cerebellum. So that's when they're just gonna stand there, close their eyes, and just observe their sway at all. And then another one would be rapid hand movement. So sit back down. Put your hand down on your laps and just come like this. Make sure they're doing that. There's no interruptions in that. And then use a nose to finger. So say looking at me, touch your nose. And then you're touching my finger. Touch your nose. Touch my finger. Touch your nose. Touch your nose. Touch my fingers.
That's hard.
And make sure you're making the person reach far out. Like, don't be center.
It's hard as it is.
Is there anyone who's oh yeah, and then close your eyes. Finger your nose.
Trying to embarrass me right now.
There you go.
You got that.
Oh, and heel and toe.
What? Heel and toe.
You don't. Heel and toe once. Yeah, there's this one to like heel to shin.
Oh,
that one. Yeah.
There you go.
Would you line down for that right now?
Yeah. All right, you're good.
The first step is just inspection. The book says that male patients should be shirtless and female patients should be gowned because you're going to do a skin-on-skin exam. Yeah, I just wanted to see without your shirt on. So the first step is just inspection. You just look at the patient. Are they breathing hard? Are they in a tripod stance? Like for emphysema patients, you know, they're having a hard time breathing, so they're in the tripod stance. Are they breathing through pursed lips? Do they have a cough? Anything like that. So you're just looking at the patient. If the patient does not have their shirt on or their gown, you can look at their skin on their back or their chest, if they have any kind of rash or anything like that, et cetera, et cetera. So after you do your inspection, the first step is to do, you can do kind of palpation of the trachea. So you can do it from behind. I'm going to palpate your trachea now.
What is that?
So you feel to make sure that it's midline and that it doesn't deviate to one side or the other. And so if it deviates to the left and he has a left-sided problem, what could it be? If it's deviates to the right and he has a left-sided problem, what could it be? Okay, good. Y'all know some stuff.
Can you say that one more time, quick?
So the next thing would be, after you check the trachea, the next thing would be tactile fremitus. So basically you're feeling for the reverberation from the lung. You're feeling if there's too much air, if there's too much fluid, if it's normal. So you're gonna place the sides of your hands either side and ask the patient to say 99.
99.
Every time you place your hands, so say 99.
99. 99. 99. 99.
And the book says every like 2 to 3 rib interspaces. So you want to do it in enough places that you get all the lobes of the lungs. So there wasn't like a number of places or like specific places to do it, but if you make sure you do it enough to get all of the lobes of the lung. So if there is increased tactile fremitus, does anybody remember what you might have?
A lung problem.
Okay, so I didn't remember either.
Pneumonia.
So you have like fluid in the lungs if you have increased tactile fremitus, so like pneumonia. If you have decreased tactile fremitus, you have like air. some condition with like too much air.
Yeah.
So the next thing is percussion.
They would be hyper resonant.
So like pleural effusion would be for decrease, and increase would be consolidation of the lung.
Right. Okay, so the next thing is percussion. If y'all remember, this is where they taught us like there's 20 locations, so like 10 on the back and 10 on the front. Again, it also said as long as you get enough, it's like every 2 to 3 rib interspaces, as long as you're getting enough spots to get all of the lobes of the lungs. And if you have when you do the posterior side, if you have your patient roll their shoulders forward like they're going to give themselves a hug, so you can get more space when you're doing it. Using your chiropractic index fingers, it was very specific in the book, and I don't know that this really matters, but your non-dominant hand down as your percussive instrument and your dominant hand as your percussor. I have no idea that really matters, but so you're gonna just tap on your finger, one finger with the other finger, and move down, and you're listening for what sound? Resonance. So it's a resonant sound. If it's hyper resonant, that's not good. If it's a dull sound, not good. Unless you're over a solid organ. So like once you get to the diaphragm, it's going to be dull, et cetera, et cetera. So it's like 10. So you're going to start with the apices. You want to make sure you get the apice on both sides and go down. Get the edge of the lung, make sure to tickle your patient, and then do the front. For female patients, make sure that you're having them guard and just go between breast tissue.
Make sure you know how many lobes are in one lung.
What?
I'm reminding people to know that one lung has more lobes than the other.
Oh, yes. So left lung has 2 lobes, right lung has 3 lobes.
Magic Johnson, represent.
So the next thing is auscultation. So you basically do the same spots that you did for percussion for auscultation. You do front and back. There's obviously, again, to get all of the lobes, you want to listen to all the spots, especially if you think the patient might have some kind of consolidation in one lung or the other. You want to get the lower parts because that's where it's going to settle. So you're going to listen to your patient, and tell them every time that you put down the stethoscope, you want them to take a deep breath in, because you want to listen on the inhale and the exhale. So, breathe in for me, and out. And every time I put the stethoscope in. And so on and so forth. And so the sounds you might hear are rails, which means
Train.
that's one thing that it could be. So it's a crackling sound. It's usually on the inhale, and there's 2 types. So early rails, so like on the early part of the inhale, is usually chronic bronchitis or asthma, and late rails, so late on the inhale, is usually pneumonia, or it can be congestive heart failure or fibrosis. There's also a wheeze, which is usually on the exhale, but not necessarily exhale, and that can be croup or emphysema, and that can also be bronchitis. And then the third sound that you might hear is pleural friction rub, and that's on both the in and the out. And that's it. The book said it sounds like leather rubbing together, and it's basically there's inflammation in the lung and like a lack of the normal fluid level, and so the lungs actually rubbing together when the patient breathes in and out. So you actually have like the lung rubbing together. So that's it.
Listen to like a sound on the internet, it'll sound.
Yeah, it does. I have actually heard that. It sounds really gross. Like it's not good. So that's it. So,
like Kate said, if you want to sit like that for the whole exam, you can. Males, they want to be shirtless, and females in a gown or some sort of coverage. First thing you would do when you see the patient, you would inspect. You look at the chest for any edema, any sort of breathing issues. So if they're breathing a little faster or whatnot, a little more uncontrolled. You can check for cyanosis too. That would usually be checked by looking at their hands in a way, just palpating to see if they have any discoloration or whatnot. Another test you can do is capillary refill. So you just squeeze it into the finger like that, and hopefully it goes from white to red pretty quick. Usually about, I think, 2 seconds is what the normal time is. So yeah, it's okay. Next is a way to check for aortic coartication, which is by palpating one wrist, and you have a feeling for the radial pulse, and then you would palpate both at the same time. If there's a big difference between the two of them and how you're palpating, that could be a sign of different sort of aortic coartication. Next would be another thing you can test for is collapsing pulse, which is when you start palpating the wrist on the same side, and you ask if they have any shoulder issues, because you will be jerking your arm pretty quickly over your head.
Okay.
So you're gonna feel the wrist right here, and then what you want to do is bring it right over their head pretty quickly, and you want to see how fast it drops, and if they have any lightheadedness while it's going on, or if they feel any sort of like discomforts in their chest. Next on the list would be you could palpate and auscultate the carotid artery. So if anybody didn't know, you get these right here, and you have them point back, back or forward. No, I got it backwards in my head just now. Okay, have it go forward.
Please
First
have those
time.
on the right way.
So I'm not going to put them on so I can hear everybody make fun of me while I'm doing this. You would first find the carotid artery, and then you would put the diaphragm on there so you could hear the different sounds. And if you would look for like a bruit or like a kind of rough noise if there's an issue, but normally it should just sound kind of like a pulse feels. The next would be the aortic valve, which is going to be right along the second intercostal space on the right side. So you palpate, find the sternum, and kind of just go right, little lateral to it, and you palpate or auscultate right in that area using the diaphragm and the bell. And then you would, let's see, what else is in here? Then the pulmonary valve would be on the other side of the sternum. So you go on the left side of the patient, you can go down to the second intercostal space, go to the left side. And then you would look for the, the pulmonary valve, which is, you have the tricuspid valve, which is now 2 intercostal spaces below the last one we palpated. So we go to the fourth one, and you would use a diaphragm and the bell, and you also take both those areas, listening for any sort of abnormal rhythms to the pulse. And then you would go to the fifth, would be the mitral valve, which is go to the 5th intercostal space, and you want to try to go mid-clavicular line to find this. And whenever a patient is lying in a recumbent position, it's easier just to feel the pulse. And if you kind of rotate them to the side, so it's kind of difficult to show this, but it was the point of maximum auscultation is when they're lying to the side and they rotate them to the left, and you should be able to feel or hear the pulse or the beat of the heart at a more prominent sound. Is there any other thing for the heart?
When you're listening for breeze, you're going to flip from the diaphragm to the bell.
Yes.
So make sure that you're doing
for the carotid artery goes diaphragm.
Valve.
Yeah.
And then any other area when you would check for bruits.
So what I didn't read is are you supposed to do diaphragm throughout, like diaphragm, 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 and then the bell, or do you go diaphragm, bell, or does it not?
No, I did one and then the other. So you do all diaphragm and then
you
the
do all
bell.
bell. Okay.
Because really what you're hearing is for something off. So breweries are more for the lower pitch, so then you're going back through.
Okay.
And like for the murmurs to recheck the sounds. So you're kind of scanning the diaphragm first.
Okay. Anything else I'm missing?
Oh, when you hold it, I noticed this on blood pressure too. Your fingers should be like this. I see a lot of times when people are doing a blood pressure, you've got your thumb over it. Your thumb should never be on the top of either side. So your hands should always be around it. Does that make sense to everyone? There you go.
Right.
Is the contour of the abdomen right here, and there's 7 F's. There's fat, feces, flatus, gas, fluid, fetus, fibroids, or fatal growth tumors, and those will be something that you look for. A normal abdomen will be either flat, rounded, slightly rounded, or scaphoid, hanging down just a little bit. And distended or protuberant is obviously the ones that have the 7 F's, or ascites, which is the fluid within the abdomen. The next thing, oh, I didn't bring the hammer. Okay, the next thing you would do is the reflex, where you're drawing diagonally from outside to in 3 directions. So making like from ribs to umbilical cord. And you want to really dig in, but you're not going to make them bleed, but you want to draw out the reflex, or else you're not going to find anything. And so this is testing for T7 to T9, T9 and 10, and T11 and 12 right here on both sides. And what it should do is you should see the belly button draw towards where you're dragging from. Okay, it's going to react towards where you're poking. Okay. Then you'll inspect for any abnormalities, rigidity, stretch marks, scars. Look at the umbilicus and see if it's everted, because that could indicate intra-abdominal pressure. Look for hernias, which will be palpable. Look for a deviation of the umbilicus. Then you'll start with your auscultation. I forget if that's a specific direction. Okay. Start with the auscultation. You do the bell first for vascular. Okay, so you're doing the bell first. The right lower quadrant will be the right iliac artery, and you're listening for bruits or thrills. The right quadrant will be the right renal artery. A bruit here will not be like a AAA, it will be renal artery stenosis. And you'll listen to epigastric for aorta, left renal aorta, left renal artery, and left iliac artery. And then you'll switch to the diaphragm for gastric sounds. Listen for at least a minute to confirm that there's gastric sounds. There should be between 5 and 30 per minute to be normal. If there's an extreme amount of gastric sounds, there's probably indicative of intestinal obstruction or diarrhea. And if it's decreased, basically absent, you're thinking peritonitis. So right lower quadrant is you're listening to the cecum and the appendix. This will be the ascending colon along this this edge here. Right upper quadrant is liver, gallbladder, and right kidney. Directly midline is pancreas, above the umbilicus. Left upper quadrant is spleen and left kidney, and the descending colon. And then left lower quadrant is sigmoid colon. So an important thing to note next for palpation is ask them if there's any tenderness. Do that last. Don't start with the tender or do that in the middle. And that, so say that they have left lower quadrant tenderness, go counterclockwise and start there. So start at left upper quadrant, right upper quadrant, right lower, and then last is right or left lower quadrant. Warm your hands. Start with one hand first, which is about a half-inch deep. It's not very deep. And then do deep with two hands, 1 to 3 inches. Do not palpate a rigid abdomen because that is most likely peritonitis, which may be due to a rupture of the appendix. Palpation may increase, it may do more harm and more damage. Abnormal feelings, abnormal palpation will be nodules, rigid guarding, or tenderness. If there's a mass, describe it. So there's hard, irregular, that's probably malignancy. Firm with smooth or irregular surface could be cirrhosis. Fatty liver is soft and smooth. Soft to firm, but smooth and tender could be congenital heart failure. Soft and tender is hepatitis.
You should percuss before you palpate.
Just before palpate. Okay.
You should always go off with the percuss.
Okay. Percuss before you palpate. We'll make sure of that.
What about the reflex?
What about the umbilical reflex? Is that before percussion or is that before palpation?
Yes.
Okay. So, an important thing to note is that the liver will enlarge towards the right lower quadrant. So start there to palpate the liver. Start from the right lower quadrant and go upwards to feel the liver, to feel if it's enlarged. The spleen enlarges towards the right lower quadrant, but it's in the left upper. So start from the right lower and go towards left upper to palpate the spleen. Normal finding is no tenderness, it's soft, there's no muscle guarding, there's no masses, there's no bladder distension. And abnormal is rigid, there's tenderness, there's guarding, or swelling. So this will be the same. I bet you they said in the book that use your non-dominant hand down. I don't know why that matters.
They were very clear.
Got to make sure. So this is a very specific order of 12 spots. Okay, so start near the umbilicus in the right lower quadrant. That's number 1. Number 2 is down. Number 3 is lateral. Number 4 is straight up from there. Number 5 is medial. 6 is superior lateral. 7 is almost just straight midline. 8 is right across from there. 9 is lateral. 10 is more medial. 11 is lateral again. 12 is down. 13 is medial. So the lower quadrant, both the lower quadrants are mirror images of each other, and both the upper are mirror images of each other. And then you would have the patient sit up and do the kidney punch. Does everyone remember the kidney punch? You want to see it?
Yeah.
All right, sit up. face this way. Kidney punch is here. Everybody can see. And pain would be indicative of some kind of renal inflammation or disease.
Start gentle on a real patient.
Don't just go for it on the first try.
They actually have kidney infection right now.
Okay. So on the percussion, if there's pain in the right upper quadrant, it could be hepatitis, hepatomegaly, or gallstones, or kidney. And if it's kidney on one side, that is polycystic kidney, and if it's on both sides, both kidneys, it's hydronephrosis. To the left upper quadrant is splenomegaly or spleen abscess, and then kidney. Left lower is diverticulitis, constipation, or ulcerative colitis. Right lower is appendicitis. Try the recoil test if that's in your diff diet, and test for low white blood cell count if it's not extremely acute, and then you just go to the hospital.
The recoil test is extremely effective. We will use it on real patients. Just send them to the ER when it's positive.
This could also indicate Crohn's disease or ileocecal valve obstruction. Did I miss anything? That's all I have.
Oh, and then you talk about rebound. So like if someone has like appendicitis and you touch in the other areas, it'll still hurt where the appendix is.
Okay.
So it's very useful. You'll have patients come in, they'll come to you, it's easier. You will send someone to the emergency room for appendicitis, so. If not, it'll be your significant other, like I did.
What is the recoil test?
No, rebound, so if you push in a different quadrant other than where your appendix is, the pain will still refer back to the appendix. So a lot of times what you'll do is the recoil test, and then that'll hurt, and then you'll confirm by pushing in another area and say, does this hurt? And they'll be like, yeah, but it's over here. Just send them.
Anything else?
Nope.
It's early. So Sperling's A, lateral flexion and extension, overpressure. Sorry? Yeah. B is lateral flexion, ipsilateral rotation, and extension.
Yes.
So D is like the rotation, ipsilateral flexion, extension.
Oh, just do Sperling's A.
Yeah.
So it's going to passively flex towards the radiating side,
And extend back.
and then, yeah, compress.
Yeah. Yeah, okay, so distraction, you can do that supine. Face up. I can't talk much higher.
Oh, yeah, you're sick with it.
Yeah, sorry. So we're on the hip, and then just pull out. It goes about 14 pounds of pressure.
So cervical distraction,
Distraction.
you want to do it this way. So instead of doing it both bilaterally from the occiput, you want one hand here, one hand underneath the chin, and you're going to distract that way. And it should be done supine.
And then upper limb tension. That's one of the
Sorry, my hands are freezing.
chest and shoulder. 180 degrees abduction. External rotation.
Oh, you're just looking to, it's if they have ridiculous symptoms, distraction.
So only do it if they have ridiculous symptoms and you see if you.
You're looking to see if you relieve it. I learned back in school that you could do it, and if it increased pain, it could be a spray. That's not really the best stuff for it. You really should be doing O'Donoghue's for a spray.
And then it'll probably also be based on assessing
A lot of people, if you don't have ridiculous symptoms, a lot of people are going to feel relief. of cervical distraction, but I wouldn't count, that's not really positive. It's positive if you're actually relieving the radicular symptoms. And that's what you're doing it for. Sorry.
Press the shoulder on the increase baby action and rotation. And extend the wrist and fingers, forearm coordination, extend the elbow, and then move to the left or the right. That causes pain in the forward, and that should alleviate.
That is correct. Go both directions, away towards which one increases, which one decreases it.
Also, over the wieners.
Yes.
Yeah. So there'll be, if there's pain under 60 degrees of rotation, that's also.
Yeah, less than 60 towards the ipsilateral side.
Okay.
Make sure, just so you guys know, like there's multiple ways to do one orthopedic test, right? You pick up 2 books, they don't have the same. There's going to be one on the rubric, okay? But you have multiple sources to be able to do an orthopedic test. Just make sure if how you do it matches one of the sources you're allowed to use. Does that make sense? If you're like, oh, well, I did it, and you get it wrong on an exam, and it's from a book that's not on the list of approved stuff, it's not going to count, right? So everyone understand that? So make sure, I know they send it to you when they send you the capstone. Make sure what you do and how you normally do it is on one of those books.
For the cluster, do you only do that one, or do you also do?
You only do A. Nope, you only do A for the cluster. So the cluster is spur length, upper limb tension A, ipsilateral rotation, and cervical distraction. So. Good job. Keep going. Sorry.
Okay, so this spur lengths. What else?
Cervical flexion rotation. So when they lie down for the cervicogenic headaches.
Oh.
Okay. Go ahead and lie down.
Body is seated.
So it's cervical flexion and then rotation. And then you're looking from side to side, yeah, to see if there's a decrease and increase in pain. If it's causing the headache, that's it. Increase in symptoms.
So it's not like you have to push against your hand. It's not like a belt.
No, you do not agree with it straight. The Jackson's hyperextension. Yes, so go ahead and sit up. So what you're gonna do, oh, go ahead.
Just extend that, and that's just upper pressure.
Yes, and if they have pain just with the extension, it's already positive. You don't have to continue on.
What is that? Jackson's hyperextension. Facet.
And then springs would be the other one for facet. Springs, so you just basically push on the spinous process of the facet and jam them together.
Is that a lot like the transverse movement?
Yes, we're just doing it. You should go over here.
So Jackson's lateral flexion, and then forward and overpressure turn,
And then the Cody's is one, you're gonna see that a lot in practice. Like, I never really have people do it, but people will be like, oh, they'll come in and actually tell you, like, this makes my pain feel better. The Cody's. So you will get patients that'll tell you that, so just know the ortho, because you don't have to have it repeated. You can just write in your exam positive for this. Yeah.
That's already too much.
so just here.
It's a relief of nerve retention. Or it's positive for nerve retention.
So compression, so just cross your arms across your chest like that.
Yep.
And then you're just gonna put overpressures on it. Do it. You're looking for an increase in pain. And then distraction, just like that. positive, again, it's increasing pain, and then the same as with the cervical springs, so you're just going to push. Sets. Looking for an increase in pain. Okay, TOS. So for all of these, what you're going to do first is palpate on your arm for the radial pulse. So here. We're going to do absence, so you have them extend their arm out, bring it back a little bit, extend your head back. Take a deep breath. Hold it. Then you're looking for a change in the pulse or a recreation of the pain. A recreation of the pain. Oh, and I forgot. On that one, extend the head back, and then they rotate it to the side being examined. So to this side. Yeah, there you go. Alright, next one is right. So you have your arm again. You're going to bring it back a little, bend it after you have the radial pulse, right here. And then you're just feeling again for the change in pulse or recreation of pain. And then you're going to bring it straight up. Looking for the same one. It's really heavy. Yeah. Not helping at all.
2 girls call me fat now.
How does that make you feel?
Okay, and then hyperflexion is kind of the same. So you have your arm again. On the radial pulse, and then you're just gonna like support their shoulder a little. Bring it back and extend it. And that should either change the pulse or recreate the pain and the symptoms. Bruise. You're gonna ask the patient to bend their arms like this. Yes.
Nope.
I'll do it. So this, kind of extend it back. You want their like elbows a little bit back. Do this for 3 minutes. You're gonna look for
Started.
go. Heaviness, tingling, recreation of the symptoms or pain. And the last one is Janelle's on the scalings. So you're just gonna come around, find kind of where they attach, and you'll just tap. And then that should recreate the tingling down the arm. Okay, scoliosis. Do you want to lay face down? This one, you're just observing. So you're going to look like in here for rib pumping on one side or the other. Get up.
Short nap.
Sorry. Okay, go ahead and stand. So Adam. That way. You probably have them in a gown. Yeah, you just have to take the shirt off. But you stand behind them. Go ahead and bend forward. You're going to watch as they bend and see if there's any kind of a curve through here. And the last one for scoliosis is just lateral flexion. So again, just observing. Like asymmetry to one side or the other. Well, while you're standing there, we'll do shufflemans. Arms up, bend to the side. If you have pain on the side when they're bending over here, that's intercostal neuritis. This side is muscle movement. Good there. Okay. And I don't have a measuring tape, but she bears, this is for AS. So you're gonna find the level of PSIS, measure down 5 centimeters from there, mark it. From that dot, measure up 10 centimeters, and then you'll take your measuring tape, hold it there, and then the patient, you're going to instruct them to keep their knees straight and bend over as far as they can. And then you're going to measure between the two that are 15 apart.
6 or more. Looking for 6
Yes.
or more.
I think you're right. Less. I think, yeah, less than 6.
6 or more is good. We're looking for 6 or more. If you're looking for less than 6, you're sick.
Wait, come back. Actually, yeah. Okay, so, and then again for AS, chest expansion, measuring tape, you're gonna go like around the level of T4. Here. You're gonna hold it, say take a deep breath in, and then out, and you're gonna measure the difference. You're looking for it to be like 1 to 3. Yeah, normal is 1 to 3 inches between the two measurements. Anything lower indicates AS.
Inches or centimeters?
Inches. Yeah. And, all right, Forrester's bowstring.
Okay, and then you're going to instruct them to get up from this position to a seated position. So you're just going to watch them. So, however is easiest. Great. A positive on that one, they'll say there's localized pain in their thoracic or their TL region. Or if they just can't do it.
These are also the biggest to remember for your boards. They like to ask stuff.
Amos?
Especially the
Yeah.
With two S's, right?
And then, yeah, that's it.
Alright, first one we're going to do is slumps. So sir, I'm going to have you sit facing the crowd. I'm going to have you slump over for me. What you're going to do is you're going to add a little overpressure on the T-spine, and then I'm going to have you extend your legs out, both, or one. Actually, you can just do one at a time. Extend it out, and then you're going to dorsiflex the foot. If at any point he feels pain during this, you can stop. That means it's we got a nerve traction issue. If he does feel pain at one part, I ask you to extend your head back for me. That should alleviate the pain if it is a nerve traction issue. It can also hint at a disc if that doesn't alleviate it, but it's more of just kind of putting that together. The next one is straight leg raise. I'm gonna have you go face up for me. So basically you're gonna take the affected leg in straight leg raise, and you're going to literally raise it up, asking where he feels pain, make sure that the knee doesn't bend at all. If he feels pain anywhere below 40 degrees, that's most likely a disc herniation. It can also mean that there's some traction issues if it's above that, so nerve traction issues or adhesion issues. Then there's cross straight leg raise, which is basically, or well straight leg raise. It's basically a straight leg raise on the opposite leg. Same rules apply, 40 or less if it causes the same recreation of pain. So that's basically what you're trying to do with all these orthos, and make sure it is the same creation of pain that they came in to see you for, because some of these can cause traction issues with the nerve. That's not what they're coming to see you for. And then passive lumbar extension, go face down. This is for facet, by the way. That was your lumbar orthos. So for this one, it's basically kind of like the opposite of the straight leg raise. You're gonna basically take and raise both legs off the table like this and slightly distract, and they should feel it right in their low back. If you feel some heaviness in your low back, we're kind of looking at some lumbar instability for that. Then we have the storch test. I'll have you stand up. And you can face that way. I think it'll be best. So basically what you're going to do is you're going to grab your right leg, right knee, so like pick it up, and then flex back over your lumbar spine. You're obviously here to catch them. You're looking for any recreation of pain here. It's going to jam the facets together. And basically, it's kind of a facet kind of pars deal. Oh, they do pars. Okay, so sorry, figure four. You don't have to pick the leg up, do figure four. Make sure you're there to catch them. You don't want to fall over. Then you have springs. I'll have you go face down again. Springs is pretty easy. Just springing into the spine, all the lumbar spine. You should also do it unilateral, and you're just feeling for the motion in that. You should feel if it recreates any pain, especially if it recreates the pain that it came in with. Basically, you're just jamming facets together again. And then for your lumbar hyperextension, you first, it's kind of like the O'Donoghue's of the lumbar spine. I'm gonna have you come up into the Sphinx position. A lot of patients won't know that. I know that he knows that. And see if that causes spine, or see if it causes any lumbar issues. And then if not, I'm gonna have you kind of cross your arms for me. And then I'm gonna pick him up and just relax him, and that's your passive. And that is your.
I'm gonna do a sacral thrust. So basically, just put your palm on the S2, and just gently thrust. See if the pain increases. Thrust a couple times, and you roll over. For Gainslin's test, you would
fingers, fingers. Yeah. Make a figure 4 and then stabilize the others. ASIS and gently press. See if the pain increases on the SI joint. For SI distraction, palpate the ASIS and push to lateral posterior. Was there a pain? Okay. It's a positive, there's a pain on that side. And the thigh thrust up. I roll over. I put my palm on the sacrum and then just press a couple times. If there's it's a positive, there's a pain. For a compression, can you roll the face? SI compression, you will find feeling it and just press gently, and if there's a pain, causes it's a positive. You did.
This is called the ancient art of measuring spinal range of motion. All right, so I'll start with cervical. Let's see. Let's do lateral flexion first. So on everything, you can do it bilateral. Bilaterally, you want to have them do 3 warm-ups, and then you want to measure 3 times and take the average.
Technically, it should be skin on skin.
We're not going to do that yet, but
we'll keep it short and sweet.
Yep. Should we do this short and sweet, just like me? So then, lateral flexion, go ahead.
Yes.
Lateral flexion.
Skin on skin.
To the left. Okay, and then to the right. Good. And then when you're measuring
can
this,
we just say to them like we would do this skin on skin?
Yeah. You think so?
Because like.
Isn't it boards that requires? Just make sure you say skin on skin.
So then on the bottom one, you're going to be sure that you like subtract the difference from the top and the bottom. And then, let's see, that's that. You're going to make sure that you have your inclinometer zeroed out. Extend back. Good. Okay. And you want to kind of know the normative values, what they should be. Okay, go ahead and flex forward. Okay. Let's see. Go ahead and lie on your back point. For rotation, you're just going to use one inclinometer. And you're going to have them raise your head up just a tad, and then look to the right. Okay, good. And then go back to neutral. And then to the left. Okay, good. Okay, so that was cervical. Good. Be sure to subtract the difference.
Your hand's really high. Yeah.
Got extra lumbar.
Yeah. Yeah.
All right.
You're measuring full spine flexion. Should be L1.
That's fine. That was it. Okay. And then for extension. And be sure to have the inclinometers out of the way of each other so that you're not like ramming them together. Okay. you're gonna right. And then rotation.
So your lumbar flexion, extension, and lateral flexion would be measured. You'd have one at L1 and one at the sacrum. And then when you do your thoracic rotation, you're going to be at T1 and T12.
When do you ask? Every time. Oh. What about the warm-up? Oh.
Good.
And they should be bent at 90, not like this.
Yeah.
Yep.
Yeah.
Abduction. So you're gonna go ahead and put it in the joint space in line with the humerus, and then go ahead and have them abduct, and then you follow their arm up.
Hard to see when you're standing in front of them.
Yeah, and that can't really.
There's no way to do it.
But yeah, so pretty much for these, you're gonna put it in the joints, like the glenoid humeral joint, and then have them abduct. The next thing we're going to do is adduction. So if you could go ahead and stand up. If you you're gonna put it here, you go lean forward just a little bit and bring your arm in. This is for adduction. So you're gonna start from neutral and go out as far as they can go over. Same thing with flexion extension. You're gonna go here and go ahead and yes, palm up. And then go ahead and go up. Go there. Good. And then extension would be back the other way. Good. Any questions on those? Okay, now we're going to do internal, external rotation. So if you can go ahead and start here.
No, here.
Yeah, that's my fault. Sorry. It's okay. I'm just like this way. So this way. Internal.
It should be like 90 degrees essentially for either. It should be 90 and 90.
Yeah, that makes more sense.
If you look at the paper. Yeah, otherwise you'd only have like maybe like 5. So you start at neutral. This is your neutral. Neutral's here. Yeah. That's up and down. And you can do it on a table, sideline, or other. So it's here, up, and down. Okay, next.
Next we have elbow. Just extension. Go ahead and hold your elbow out. Here you're just looking to see if it's at 0 or if they have any hyperextension. From there we do flexion, so you go ahead and flex. There we go.
So just so you know, like the knee and the elbow are the same. Like you're not really measuring 0, you're just making sure it gets to 0. What you're worried about is if someone can't fully extend the knee or the elbow. It'll be stuck in a flexed position.
Okay. Then we'll move on to wrist. Make it funky. Just here. And then from here we're going to do flexion. And then extension. Again at the joint space. And then we're going to do pronation and supination. So you'll have them come to the front. You'll start here. And then go ahead and supinate. So you follow their wrist. And then same thing with pronation. This way. Trying to keep this one still. This one keeps getting stuck. Go ahead and sit down.
Just do knee and hip.
Knee and hip. Okay. For knee and hip, go ahead and lengthen your face up. For hip, we're going to do extension. So it'll be at the joint space, and she's going to go ahead and extend one leg up from here, and you'll be measuring from the joint space this side.
Flexion? Yep, that's what I mean. I got confused for a second. That's what I meant. Don't watch what I'm doing more than what I say. Go ahead and go up. So you can hear. Good.
Do the legs straight or bent?
What's wrong?
Do you keep the legs straight?
I just do it here. Reflection.
But you have to keep the legs straight.
Yes.
Yeah. And then you do.
And then extension would be on the stomach. And then have them extend up. So flip over. So be here, and then come up. Be here. Then lie on your back. And then you would have it here, then abduction would be out, and then in, and then, yeah, and then just pull. I'm measuring it incorrectly, but that would stay straight in there. I should have put this one in, but that's it, and then flexion, you can do it on your stomach for your knee. So lie, flip over. Go here, then flex up the knee, and come up. So this thing, to me, I find it easier because this is just always at your joint. And you make the joint move. If it's at the joint in the correct spot, all you're doing is just having this follow. I didn't make you do toes and fingers.
That's okay.
Apprehensive relocation. Use this arm so you got quite easy. Take it 90 degrees, and then you're going to push forward. This is testing anterior stability. So moving it back and forth, anything there. And then you would do relocation, so same thing. Press on the humeral head and redo the same motions, and if it relieves their symptom is positive.
And when do you do relocation?
When they have pain, when apprehension is positive.
Yeah, so you only need to do it if apprehension is positive.
And then
apprehension is negative, there's no point.
So during Capstone, when you asked, what are our findings for apprehension? Before
So if you didn't
okay.
have a positive apprehension, unless they straight up tell you to do apprehension and relocation, depends how it would be asked.
crank test is almost the same thing, except it's at 160 degrees. You just load the arm, and then it's internal and external rotation at 160.
Make sure you're really loading.
Axial load.
Yeah.
Okay. Sit and face that. Loading. Grab the humeral head and shift back and forth, anterior and posterior. And if it moves one direction more than the other, it's positive in that direction. All right, shoulder impingement, stand up.
You want to feel it? Test and I will shoulder.
Painful arc, you're just gonna go hands down in this direction, raise your arm up, and you're just gonna stop wherever they feel pain. Pain at 170 to 180 is AC joint impingement, and 60 to 120 is
Those are the most know your numbers. So what is it in impingement? 60 to 120, 170 to 180 is your AC joint.
That's not in scaption? That's just really the side, or is it in scaption?
It's just the side.
Yeah, side.
Okay, it's just the side. Okay.
Yeah, you're not doing it. It's not like
Here.
yeah, which is in scaption. This is at the side.
Hawkins kitty, so 90 degrees here. So you're going to reach under, and then you're going to internally and externally rotate your arm. No. Empty can, stand up on it. So you're in scaption, turn your hands over. So first flip your hands over, and then we would test this way, and then have them turn internally rotate and test again. That is for subacromial impingement. Cognus drop arm, same thing, stand up again. This is for a full thickness rotator cuff tear. 90 degrees, abduction, external rotation. Relax your arm in my hand. And then you can drop their arm. If they can't catch it, then it's fully torn rotator cuff. Here's you can sit down.
Don't warn people you're doing it.
So knees, depress scapula, internally rotate the arm, and then you're going to bring it up into flexion passively, feeling the pain. And then they have external weakness for shoulder impingement as well. And it's I'm pushing this way. And then that's for instability and impingement. And really the only two tests that you need to add for labral tears is the Clunk test and O'Brien's. And O'Brien's is the one that's the same thing as empty cam, but it's 10 degrees abduction, press down, no be pain. And
use O'Brien's at empty cam.
Clunk test, lay back down, face up. Clunk test is almost the same as cranks. Instead, it's axial load and it's pivoting in the joint instead of internal external rotation. So crank is internal external rotation and clunk is feeling for clunks because you're actually loading, moving it in rotation.